you for joining us on this beautiful day. So today is a very important session, and as we'd mentioned, it is an interactive session. So we have two of our advisors and team Aarohan facilitating today's session. We have Githanjali and Smriti, who will be facilitating today's session. Just going to introduce you to Githanjali. She has spent 20 years in the corporate sector with companies like Gartner and Capgemini. She's also worked in the UN, ILO, and UN High Commission for Refugees. She currently serves as an expert advisor to UAE University, and she's based out of Oman. She's also had personal experience with pain and grief in the past, and that's one of the reasons that she's also founded a not-for-profit organization called Ashwata, which is building awareness about palliative care and end-of-life issues. So thank you, Githanjali, for joining us. And we have Smriti, a director of programs at Palliative India. And like I mentioned, my mentor and boss. Thank you. And thank you and welcome everyone. So let's, it's an interactive session, so please be ready to turn on your mics. So thank you and welcome.
Thank you, Shreya. I think I'll take it from here. So first of all, welcome everyone. Thank you for joining on time. We have about an hour and a half, which as usual will be quite intense. If the last few sessions have been any indicator. So today's session is going to be particularly interactive because we want to hear from each other. We want to discuss with each other about the goals that we've set for ourselves, what we're trying to achieve. And we're going to start the session by first spending some time talking about what's the biggest change we want to make, and I will lead us into that. And then we'll spend the second half of the session talking about goal setting itself and what that means, how to think about our projects going forward, and what's coming up in the next few sessions that we have. Okay. So just taking a step back and thinking about the last 2 weeks, I would say, of sessions that we've had. We've talked about palliative care. We've talked about the landscape of palliative care. We've talked about what it entails, who it covers, the types of issues that we see. Some of them we have experienced personally. Some of them are newer to us, maybe not something that we have experienced ourselves. So we've spent some time trying to understand the landscape of palliative care. Right? That's the first piece, I would say, that we've done. Now, after that, once that, at the end of the second session last week, we sent out a questionnaire asking you to think about the projects that you've been working on or you're planning to work on through your Aarohan journey. Now, when we did that, we received responses from almost everyone in the group, and we received a variety of project briefs in the form that was filled. Some of us are still not sure what we want to do, what type of project I want to work on, what am I going to do with the journey that I'm on. But some of us have spent a lot of time just figuring out where we want to go. We've had proposals, or we've had write-ups of nursing homes that we want to set up, or institutions we want to set up, or educational activities we want to take up. So definitely there's a mix of some of us not really very sure where we want to go, and some of us being very, very sure and having spent some time thinking about what we want to do, right? And that's where we were, that's where we left off, and that's now we've come into the session on goal setting. Now, to get us started with goal setting, what I'd like and what I would request all of us to do is take a step back and think about what might be the one change we want to see in this space, in this area, right? To take a step back and think about not the project you're going to work on, not necessarily everything that needs to change and everything that needs to get fixed. What is the one big thing that you think would make the biggest difference? Right? And I'm going to invite you to raise your hands or let Shreya know that you would like to speak, so that we can get you to call your name out and you can share your thoughts. And Smriti, I'd invite you to please join in and comment as we go along. So we'd love to hear from almost everyone. So try to keep your comments to the point as possible, as much as possible. But I think there's enough time for everyone to have a say, and that's what we want to hear now, to hear from everyone, to see what you think is the biggest piece or biggest change we'd like to see.
Can I invite Ashwin to start?
Shreya, I think Zaver put her hand up.
Sorry.
That's okay. That's okay.
Zaver, you can please start.
Oh, I think one of the biggest changes that I would like to see is that there is a, sorry, can you hear me?
Yes, yeah, please go ahead.
That there is awareness that help is available, and that there is something in like this forum, which I mean, somebody like me who was in a small town had no clue about. And however many people we sought to find whether there was something like this, we drew all blanks. That was some years ago. So I think that people need to also be aware that such a beautiful organization or such groups do exist, and that help is around the corner. So once people get aware and they approach us, I think that would be a really meaningful thing for people to even know that help is at hand, and to understand, like I have in the last few lectures, what the true meaning of palliative care is. Because otherwise it is very, very confusing for many people.
Thank you, Zaver. I think that's a very good point. I think first step is to just know that there is something like this, understand palliative care. And as we've seen, there's a lot of misinformation and misguided notions about what all of this means. So I think you're very right in what you've commented on. Thank you for that.
Thank you.
Can I call out the other? Like we have 4 people raising hands. Sylvia, can you unmute yourself and speak?
Yes, thank you. I think what I want to say is linked to what Zaver has just said, but probably taking it, I don't know if it's one step further or one step back actually, but it's, I'd like to see that palliative care is not seen as a, quote, dirty word. And by that I mean, let it not be shunned and avoided because it is misunderstood and because it is positioned as being something purely close to death, or only if you're dying. So I think that whole the word palliative care is so misunderstood that it is shunned, and I'd like to see a change there.
Thank you, Sylvia.
Thank you. Shantini?
Hi, can you hear me?
Yes, we can.
Hi, good evening to all. I think I understand this question as a whole thing, like how, what kind of change I would like to see, or as a first step, what change I would like to see. Would you please rephrase that for me?
Yeah, so I think it's more of, if we were to do something now, today, what would you like to see changed?
In the future, right?
Yes.
Yeah. Actually, my observation about human beings itself, it's more obviously spiritual. We all see death as a bad thing, and also living as a bad thing. We all, most of us, feel like we are cursed, and all that. Actually, my main goal is I would like to evolve, and at the same time, I would like to see everyone evolve to a next level, where we don't fear death, or we do accept life as it is, and embrace life more happily. So that's what I would like to evolve myself. And also I want to take especially our elders who's much more closer to death, terminally ill patients as well, because the young and right now the living has more time, and the ones closer to death doesn't have much time, and they, as they already lived the life, and they have more, they think they have more regrets that they can't go back and fix anything. So I wanted to like provide or expect to create or that space that they can still feel happy about the life without regretting. So that evolution part of it, I really want to see a change in it. That's my ultimate goal.
So that's very beautiful, Shantini, to be able to take to the end of the journey without regret, and give
Yes.
people a safe space to even if the journey, that end is difficult, to find a
Yes.
safe space, find peace with that. So I think that is very beautiful, very aligned to to the dignity of death, if you will, or dignity of life, even unto the end.
Yeah, I believe that, you know, every human being deserves to evolve to that level. So I would like to, if possible, to eliminate all that, you know, corruption which occupies our mind. So I would really like to help people to reach that level. That's the change I really love to see people around me. And as much as I could, I would like to provide that.
Thank you so much for sharing.
It's an honor to meet you through this.
Thank you.
I would like to hear a lot from you.
It's a pleasure, I think, for all of
Yeah.
us to be together
Like,
here. Thank you.
Thank you. Vicharavindu, sir.
Good afternoon, all. And even yesterday, I was giving a lecture on an international platform in connection with, of course, palliative care. And the main subject I was dealing with was altruism. Without altruism, without an altruistic outlook, you will never be able to take away the pain, not only from the patient, not only from an ill-stricken man, but from the man who is having some kind of pain in his ordinary life. The very life is important. Death is the last thing you will have to think about. So, if you are going to think about the agony that a person undergoes through the physical life when he is alive, that is the part where palliative care has got an interventional occasion. It is there palliative care should go in and soothe him and tell him to shower out, to tell out all his agonies, so that you will be able to give him a soothing touch, whereby the palliative care will be effective and will prove to be result oriented. Thank you very much. And I'm on that line.
Thank you, Mr. Vicharavindu. Very nice, very nicely said. That's definitely a place where palliative care can come in and support. And it's a place where we are getting. Smriti, do you have any comments you'd like to add to that?
No, I'm just listening, and I think just with 4 people in, we've had such a variety of intentions stated, and it's gone. It's moved from practical stuff to more spiritual stuff, and I'm actually just enjoying the different perspectives that are coming in. And I think what is emerging from each of these already is a theme of living life more meaningfully, and the role that palliative care can play in enabling that. So I'm just trying to, I'm just listening to everybody, pulling a few threads together, Githanjali, and I'll come in a little bit later.
Excellent, thank you. Esther, I know you've got a raised hand, so.
Yes. Thank you, Githanjali, Smriti, Shreya, all of you. There's one thing that I would want to get into, and I am from Pune. I have visited SIPLA, and I have the SIPLA Palliative Center, which I didn't know even existed. And then I visited another palliative center, which is a 12-bed. They've got a daycare as well. So I went to both places and I said, just let me do anything at all. Just, I know from the people around me who have said that I'm a very compassionate person with a lot of patience. So I said, I can see patients, I can see people who are just lying around over there. Let me just go and talk to them. Let me just go and meet them. Let me just go and, say something nice to them rather than just having everyone else tell them what to do, give them medicine, give them this. So I said, why can't I do that? And I realized this because once there have been, I live in a society which has got about 700 flats. So there are times I see the elderly, more than 85, 90, just walking. And I am surprised that they have walkers for them. So I know the society has dog walkers, but we have two elderly people. They might be like 90, 92. They have walkers for them. And I know the family is there, has a lot of money. So when I see them, I saw this gentleman and I just went and I told him, I was like, you've got a lovely shirt. I think he smiled from year to year. So every time when I go for a walk, I go at the time that he is there, and I can see he yearns to look out for me. So I spend at least about 5 or 7 minutes. So when I went up to Sipla, I said, let me read. I know to read in Hindi. I know to read Marathi. I know to read English. I can just read the newspapers to them, letting them know that, yes, you are only physically not well, but you belong to this world because that we are from you. You can't forget that. And it's been a sad journey. I've not been welcomed back. They were like, yes, we'll let you know. I said, I have been coming to you from the past 4 years. So look at my determination. I'm not just asked you once and then gone away and never come back to you. So that is the reason that, I keep going back to just show them, I'm around here. Do something with me. So I'm just hoping after all this, I can make some change to some people. That's what my aim is. That's what I think.
Esther, thank you so much for sharing. I think it is commendable that despite not receiving where you're here to give and do good and not receiving that acceptance per se, you've still continued and you still have that desire to support. I think that is commendable. Hopefully, as we go along and as we build this community further, there will be greater opportunities. But you're right that, there are many things that we can do as individuals. Unfortunately, sometimes the society at large is not yet ready to receive, which can sometimes feel like demotivated, and there is some legwork to do till we arrive at that space. So thank you for sharing. I think that's a very important point.
Thank you.
We can see Dr. Pranav Basu have commented a lot in the chat. Doctor, can you unmute yourself and speak about your experience? Dr. Pranav Basu?
Yes. Am I audible?
Yes, sir, you are.
Actually, I feel that our goal is still a long way to go to motivate human being, people in need, the value of palliative care. Even I am shocked to know that healthcare professionals, many doctors, many oncologists do not even appreciate the need of palliative care. So I feel that advocacy and vigorous campaigning for the palliative care throughout the country is a need. Like what Palliative India is advocating and is a pioneer in advocacy. I am really proud of because I am being associated with, and I try myself to advocate the need of palliative care, and I am engaged in the Eastern India palliative care, where the terminal cancer patients are undergoing palliative care, and at the last moment. So doctors do not realize that palliative care should start at the beginning of the diagnosis, not at the end. And there is a misconception to the people that palliative care means it is dying, death, no problem, no matter, no use of having. But I have seen many patients in our clinic that they are surviving with comfort, providing comfort, and with mental happiness, and at the end also in a smiling mood. So that we must do many things. We must be there besides the patients, and what you know, that they should not feel that they are isolated, they are lonely. So we, the palliative care providers, healthcare providers, should go forward to help them. And in this way, I think palliative care will come to the scene all over India, and we will have a vision. That's fine. Thank you very much.
Thank you so much. I think that's very right. Starting with the medical fraternity itself, engaging and communicating. I think we've spoken about the gap there in terms of both the education and the support, but you're right. That is one big place that we need to focus.
Yeah.
Thank you.
Thank you. Dr. Elsa Santobi, would you like to speak up, doctor? Dr. Elsa?
Yes, ma'am. Good afternoon. Very nice to see you. I see Githanjali, ma'am. Very pleasant personality on this platform. The one thing, if you ask me, the one thing that I would like to see change in the near future is to see that availability and accessibility for the demented patients to prevent them from abuse and neglect, that what we see today in our society, even when the expectations are being lost. So this is my only one dream, to see a change that's coming up in the near future.
It's a very, very powerful desire. Yes, thank you.
Thank you, Dr. Elsa. Dr. Bijli Anand Nanda.
Good afternoon, everybody. I just wanted to say that, I feel that when the patient and his or her family start feeling that, there's no help available, they should actually have somewhere to go to. And they should feel that, okay, everything's not over just because the doctor feels they can't do anything for the patient. He shouldn't feel he can't really do anything for, because there's always something you can do, right? Like we've also learned in the last few sessions. But the caregiver needs to know, or the patient also needs to know that, okay, I can go somewhere. I can reach out to somebody who may be able to help me in some way. I think that's very important to me.
Thank you so much, Doctor. You're right. I think there's already a sense of helplessness and pain, if you will, at that. And our system can be so uncaring, if you will, that it feels like there is no recourse. So there's nothing. There's not even that support for your soul or your mind, even if physically you can't do much about it. So I hear you. Yes, I think that is a very important piece of of initiative that we need to take. Okay, great, thank you. Next, whoever is next. Is there anyone else who'd like to say something?
Like to say something.
Yes, please.
I also like, since we are going to be part of this community, it's also very important, I think, for us to in some way have a broad categorization of palliative care in all its forms. Like, some of it is really end of life care. It's not that it is not end of life care. So sometimes if the doctors say to you that, okay, there's really nothing we can do, take him home and, let him just be comfortable, give him palliative care. That is also a term that is often told to a caregiver or a family member. And yet some of us are also saying that palliative care can start at the time of diagnosis. So it's a very broad spectrum, it's looking like to me now. So I was getting a little bit confused as to how do we deal with it. Like, someone may get diagnosed 5 years before they pass. The family is on that journey for those 5 years, in which time, yes, you can help them to spend those 5 years much more meaningfully, the patient and the family. But do we really come in all those 5 years, or do we really come in when really things are starting to go towards the end? I'm confused.
I would like to just invite Smriti to comment on this.
Yes. Sure. Thanks, Zavera. I think that is a really important question that you raised. And I think that's one of the major, I'm sorry that I think we haven't articulated that properly from our side also in the last 2 sessions that we've done. So I'm going to try and address it now. One is that from what I'm hearing, like a lot of you have said, that people should know that help is available, help is at hand. And that, it's not all over. There's still a lot that can be done. Now, one of the pervasive myths about palliative care is that it's a soft science, that it's comfort care, that it's, it doesn't require the kind of expertise and technology and skill that an oncologist has or a neurologist has. And I think that is where the problem starts, because palliative care is an extremely skilled discipline. Because not only we're not specializing in an organ, we're specializing in the entire human, in the person and the family and society and the community within which that person exists. So the kind of skill set required for true palliative care to be delivered is massive. So I think a lot of people, when you say palliative care, oh, you know what? No, we're not ready for that. It's supportive care. Now, when you think of supportive care, you think, okay, it's about organizing a nurse to come and just be there 24 hours, or to come in and help the person turn around a little bit, reposition them. Those are part and parcel of it. But the expertise that a counselor needs, the expertise that the doctor needs in order to understand, okay, this person is breathless, this person is delirious, this person has agitation, which has no tangible physical cause that I can attribute it to. This person is now actively dying. Now, this is the kind of intervention that needs to come in. The kind of, on a medical level, the kind of skill it takes to juggle the different medications and the dosage to keep that person comfortable yet lucid. There's a lot of other stuff happening there. So one of the first things I would say is to let's bust this myth that palliative care does not require technical expertise. It requires a lot of technical expertise. And it is, so earlier I'd say, yeah, soft science, it's fine. It's not, it's a very, very skilled discipline. The second thing I'd like to say is that palliative care is something that can come in right from the start. Now, the degree to which the palliative care team gets involved varies. So in one of the sessions that are coming up, we're actually going to be talking about that graph, where if palliative care is at the bottom of the graph here, towards the end it expands, because as curative interventions start to become limited, that's when comfort care becomes more focused. So unfortunately, world over, the problem is that people are referred to palliative care very late, and therefore it has been associated with end of life care. Now, what can I do right from the start? I can help the family navigate shared decision making right from the beginning. It does not have to be about, okay, should he go on life support or not? It's not that. What are the choices we make along the way that will ensure that the financial burden on the family is lessened, that the impact on the children is less, that someone is paying attention to the child while the parents are being treated, right? Or when a sibling of a child is sick, is someone paying attention to the needs of the child who is healthy? Things like that. Now, I was saying that I have an uncle who's gone to the best doctors across the country. Now he's in pain, and his doctors still tell him that you're not that badly off. You don't need to get on the opioids. Why should someone be so badly off before they are eligible for pain relief? So the conversations with us now, we've been able to get in there and say, you don't have to wait to suffer before you get relief. Let's prevent the suffering, because prevention of suffering is also a part of palliative care. Tomorrow, I hope and I pray that he has far less pain than he would have had he waited for his attending doctor to start him on the meds. And the attending doctors, unfortunately, many of them are not familiar with titration of opioids. So they say, we're giving the opioids, but we'll give you a very small dose, 10 mg for the whole day. That does nothing. That person's requirement for opioids might be 40 mg every 4 hours. Right? So you see the difference it can make. So what I would say to you is, the message is palliative care is applicable from diagnosis. It comes into sharper focus as the disease and illness progresses, and as the needs of the person change, so does palliative care adapt itself to then also encompass the needs of the family, because the needs of the family also changes as things progress, right? So that's the answer to I don't know if that makes things a little clearer.
Yes, it does. Thank you so much.
You're very welcome.
Thank you, Smriti. I just want to see if there's any other comments. Yes, Colonel Banerjee and Purnima. Any comments?
Can you unmute from your end and speak?
I think Mr. Basu wants to speak.
Pranabda, please go on.
Actually, I am telling that after the death of the loved one, as I was the sole caregiver, actually in our clinic, there are 3-4 cases where husband died of cancer, and still I continue conversation over telephone. This grief bereavement support is there. The need of the palliative care. Palliative care also includes the bereavement support because the family and caregivers we look after. And there are 3 families who still continue over telephone, telephone to me, and I try my level best to make them feel that we are beside them, and this is the palliative care. And what Siti Rana was telling, that it was very excellent, and that's all. This is.
Thank you, Pranabda. I think thank you for reminding us of the bereavement part of it as well. Yes, because the suffering does not end with the death of a loved one. In fact, the suffering escalates in different ways after that. And also in a lot of scenarios when, palliative care is not, it cannot guarantee a good death. When I say a good death, I mean a peaceful, pain-free death. There are cases in which there will be certain symptoms that are what we call refractory, which means they do not respond to known medical techniques. And it could be a variety of reasons for that. There's something called restlessness, right? And some of you might have experienced that in your loved ones, where there is no known reason, but they're so restless, they're so anxious, and no amount of medication, no amount of meditation, no amount of anything can really give them relief. So not everybody is guaranteed a good death with palliative care. I'd like to sort of make that very clear. So in those kind of scenarios, when there is still some distress at the time of death, then the bereavement support systems also need to mobilize themselves in order to help the family um, cope with that experience. Because in a lot of places, I mean, we will also be talking about complicated grief, disenfranchised grief. There are different forms that grief takes. And as palliative care clinicians, we need to be sensitive to that. Not everybody experiences grief in the same way, right? There are people for whom the grief will abate, but then it'll come back in a big rush later. Now, when that happens, when we expect people to grieve and then cope and then get better, and when that doesn't happen for them the way that it happens for other people, then they start thinking, is there something wrong with me? So that kind of emotional support and psychological support, which is again evidence based. This is not just going and sitting with somebody and saying, okay, you're feeling sad, I'm here for you. Also, that goes a long way, but also there are clinicians who can also then assess, is this no longer grief? Is this now clinical depression? There is a difference between the two. Now, very often what happens is people are labeled as depressed when they're actually grieving, right? And sometimes clinical depression is missed because it maps so closely to grief. So at that point, palliative care also draws on expertise from mental health professionals to say, okay, now is it time for professional help here? This is no longer what we say, normal course of grief. So thank you very much, Pranabda, for bringing up that point.
Thank you, Smriti. I'll just add another comment to that. One of the groups that is also forgotten a lot during the palliative care journey are the children in the families that are affected. And that is another group that needs to be handled very, very specifically by professionals, because they would react and respond to grief and this whole element of what's happening in very different ways. They have delayed responses, they have acting out, they have, and as you know, the palliative care team also looks at that piece and has counselors, if you will, who are specialized in dealing with children and the way they react to grief and pain. So the journey of palliative care, like Smriti was saying, it starts at the beginning, but it all goes all the way beyond the death to bereavement and grief management as well. So it's a long journey.
Yeah, and just to add one more point, Githanjali, is that palliative care in the death of somebody or in the bereavement services. We have people who've been with appropriate support, been in our care for over 10 years. And I'm talking about people who've had spinal cord trauma and stuff like that, which can be supported. And those people go on to live very meaningful and full lives. So it's not necessary that palliative care is only for people with a declining trajectory. Palliative care can also be brought in and maintain well-being, which is not necessarily in a degenerative or a sort of, in that sort of a trajectory. So I just wanted to specifically mention. And there are children in our care who will graduate into a adult palliative care program. So, once they've turned 19, 20, they actually transition into an adult palliative care program where then they are appropriate support systems are then brought into place for them as adults. Now, it could also mean then vocational rehabilitation. The education support is taken care of. Then they transition into vocational rehabilitation so that they can engage and contribute and, be a part of society that gives them a sense of dignity as well. And they're not, we will be talking about this in a webinar in a few hours from now. But, that care is not, it's not charity, it's a right. So that is something that also palliative care looks at. Yes.
Thank you. Thank you. So are there any other comments anyone else would like to share?
I would like to ask, like, supposing you need somebody near and dear to you is in hospital and is in need of this kind of care. I mean, how would the hospital permit somebody like a trained palliative care expert to come in and guide them or talk to them? Would they be even open to that? Or do we just go in as a friend? And I mean, how do you reach out to those people?
Very tricky territory. Very tricky territory. I will not lie about it. There are some hospitals that have beautiful palliative care teams. There are some people who have Naam Ke Vaste teams, which honestly are not practicing palliative care in that sense, but are just sort of there, to say, okay, it's a palliative care team. And then there are people who are very resistant to the idea. Palliative care is still an outlier in many ways. There is a resistance because of the ideological differences that we might have, and there also is, we don't quite fit into their accounting system in that sense. So now, in a situation like that, it is very difficult. And what we need to also remember, which I'm sure a lot of you have gone through, is that once you have an illness in the family, everybody has advice to give you. The kind of unsolicited advice a patient and the family gets is unbelievable. And it's advice like, oh, my cousin's brother tried this, so why don't you try it? I have a friend who's a doctor. He's a doctor who has nothing to do with your disease, your symptom constellation, but he's a doctor, he's an ophthalmologist who's telling, so I'm just saying that I have a lot of respect for the good intentions of people. But how do you, as someone who has a familiarity with palliative care, how do you distinguish yourself from the crowd of information that they're getting? One is to equip yourself with the correct information, which is what this program is about. One is to be able to bust the myths in this way, like you asked, Zaver, when does it come in? Today, we're talking about that, right? So you are quite clear in your mind that these are things that can be plugged in. So I think it's about educating ourselves. It's about educating, being able to articulate the message appropriately, case to case. So again, it's not a one size fits all. Not everybody requires the same kind of intensity of palliative care, right? For some people, it's just that they need someone to talk to outside of their own families. And so I would say that depending on the closeness you share with that family, first see how ready they are for it. Because if you rush in too fast, they will immediately withdraw. Right. Because it takes time for people, like someone said, palliative care is not just about end of life, right? It's not about giving up. But unfortunately, the rhetoric around palliative care right now is that, if you're opting for palliative care, that means you've given up on life. So we have to be very clear, firstly, and sensitively gauge where are they right now? Do they even want to know about this? Right. Now, on several occasions, I've had family members tell me, okay, you talk to me about it, but let's not talk to him yet. Right. I get it. Let me talk to my sisters and brothers and see how they feel. And then maybe you can have a conversation with us. Then we'll decide how to tell daddy. So it might take several steps. And if they are not ready for it, then I would say don't push it. Okay. But at the same time, what you could possibly do is, depending on the city they're at, also become aware of who you can refer them to. Yes. That will actually take care of them the way that you have promised that they will be looked after. Because if I say, hey guys, there's palliative care, have you tried it? And they finally come around and say, okay, I'll try it. Where should I go? There's nowhere. Then I don't know where to send them. Yeah. Or I send them to a place that is not like, if somebody has ALS and I send them to a place that only deals with cancer, that's your one shot. And if they've been told that, sorry, we don't help patients with ALS, then they're going to be like, listen, you just wasted our time. Right. So equip yourself, do the landscaping, see how ready they are, make sure your messaging is correct, and then approach it. And it's usually, I find that on an average, it takes, I'm talking about families who are educated about palliative care, it takes me an average of a month to convince finally the patient that they might benefit from it. So don't be disheartened if there's no uptake in the first 2 weeks. Thank you.
Yes, Dr.
Ma'am, there are two. I am a volunteer of Palliative India as well as a caregiver of a patient or the patient to my wife. Now I am talking from Lakeshore Hospital, Ernakulam. She is undergoing chemotherapy. So I am not so comfort. Anyway, I have a doubt. There are two concepts in palliative care. One is high touch and low tech. Then other is high touch and high tech. What will be our goal? That's our question. That is my question.
Okay, so high touch and low tech is typically associated with palliative care, where we emphasize presence over the coldness of machinery, right? So if there's a lot of emphasis that is laid on good communication, being present, being comfortable with silences, okay to hold somebody's hand. As a counselor, I was taught if one of my if some of my patients start to cry, not to touch them, because that's the Western way of looking at it. No human touch. You know, you pass them a box of tissues. It's only when I got into palliative care that I completely well. I don't say, you know, inappropriately go and hug and kiss everybody, but I said, no, you know what, I need to hold this person's hand right now, or with their permission, right? Is it okay if I hold your hand right now, or whatever? So I'm not sure if I'm answering your question correctly, but that's not, technology means different things, right? Now, when we talk about high tech in the context of palliative care, we're talking about the kind of high tech we're looking at in ICUs, life support machines, you know, all of these different machines that are keeping people, all the tubes and this and that. There is a certain amount of technology required in palliative care also. Let's not make any mistake about that. Palliative care is not a thing that, okay, I'm not going to touch technology at all. There is going to be the need for technology, but the question really is the balance. As a person, what can I bring versus, you know, just saying, I'm just going to hook them onto this machine instead. So, and even when you're doing procedures, I've seen nurses in Pallium India do this amazing thing where even when someone is unconscious, they speak to them. And even when, you know, if they're giving them an injection, even when the person is unconscious, they actually go and talk to them and say, I'm going to be giving you an injection now. And this is for pain. You'll feel better after this. Now, in most settings, how many times do you see that happen? It's because we acknowledge that the person is still a person. They may not be able to respond to us in the way that we are talking to each other. But who's to say that, you know, there are several studies that have shown that the auditory sense is the last to go in a person, which is why we say, keep talking to people, even when they're unconscious, play music that they might have enjoyed when you knew them earlier, stuff like that. So we don't know, but we err on the side of humanity and say, I would say err on the side, but we work on the side of humanity. And that's where I say, that's why palliative care is so high touch and low tech. So it's a bit nuanced, yeah.
Thank you, ma'am.
Good evening, ma'am. Avtar Singh here. Ma'am, yes, ma'am. I'm taking care of a 32-year-old lady. She has stage 4 ovarian cancer, and her husband is, I think, 33 years old. They have come from Jalandhar. It is 5 to 6 hours way away from Chandigarh. So my question is that they have been refused chemotherapy and all sort of treatment from PGI. And yesterday night, I tried to put them in Sarai, a living quarter in a Gurdwara over here by paying rent and all. And I have shifted them to here. But right now my question is that actually one more thing. She has a 11-year-old daughter from her first marriage, and she wants to meet her, but she can't travel. She can't even walk a few steps. So what should I do? Should I let her go from here, or what should I do? Because her husband is with me. He is always telling me that he can't afford, or he can't take her there. What should we do, ma'am? Can you please advise?
Who is the child staying with, Avtar?
Child is staying with brother, but brother is a morphine addict. He's an addicted person, and he wants to take the custody of the child because he has lot of cases upon him of narcotics, and he want to show in the court that he is if court punishes him, then who will support that child. So that's why he is not allowing to visit her to meet her mother.
And this is the brother of the mother, is it?
Yes, ma'am.
Um, I have a few thoughts on this, but I'd like to hear from the others, please. Purnima and Colonel Banerjee have said, "Can the child come over?" It looks like there's some. I mean, the brother is probably controlling that situation a little bit. Can the court be appraised to obtain permission? I think looking after a very sick wife will not give the husband too much energy to engage a judicial process. Okay, so I think everybody agrees that the child is in danger of several things. Avatar, is there any, Ashwin, I'm going to ask you, Ashwin,
Yeah.
legal aid for families like these who cannot right now, he's a primary caregiver, the mother is in advanced stages, the brother has physical
Yeah.
custody of the child. So what can be done in a situation like this? Are there legal aid groups that can pro bono work on this?
This is in Chandigarh, is it, Mr. Avatar?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Okay,
Chandigarh.
Chandigarh. I can ask around. I'm not very sure, but I can ask within my circles and see if there's anything. There should be groups over there available. Sure, National University and all will have some. So I'll ask a couple of my friends and I can
What
find
we
out.
can also do from our side, Avatar, is we have in the past worked with lawyers in Delhi for the NDPS amendment, who are very, very clued into the different legalities around the NDPS and stuff like that. Now, I don't think it's as straightforward as he's saying that he gets custody of the child and therefore that is his cover, because he's not the biological parent.
No,
So
and
I don't think, yeah.
I don't
Actually,
think the court will go for that either. That's definitely
no.
not.
Actually,
Yeah.
let me clear you one thing, because one of the actually police here is very corrupt in Punjab, very, very corrupt. So they have told him, they have given the idea that if you project this child in front of court, the court might have mercy on you. That's the thing. That's why he wants the custody of the child.
So it's even the police are not always well informed about the intricate legalities of the law. The NDPS is a very complicated law. It's not that straightforward. So that can be. There's a question that was raised: does the father even want the child there because she's from the previous marriage?
Hello.
That's fair.
Yes, child
Yes.
very the father very well want child to be with him, because he know that if they leave the child in Jalandhar, they are already thinking about shifting the child to Mumbai, so that she can become a what do you say, dance bar girl or something like that. They have already planned. Even this patient's older sister, she's from Mumbai, she's married over there, and she has already planned that I'll take the child to let her finish herself, and then we'll take the child to Mumbai, and there we can employ her. That's the thing.
Hello. Hello.
Yes, Said. Yes,
Yes,
Said,
Mr.
please.
Child.
Sorry to interrupt. Actually, many of the states they have child welfare committees, which responds it's given a responsibility of taking care of children below 18 years of age. So I think they can be contacted because they have a juvenile police unit, everything, and they have also some fit institution which can take care of the children or who are in need of care and protection. So the district chairman of CWC,
Sir,
Child Welfare Committee, can be contacted.
sir, that CWC office is right behind this Gurdwara where I have stayed them. Yesterday itself, I paid around 6,500 just for a room, so that they can have privacy for that. But I think they'll first they want the physical presence of the child over here. Then only they can protect her. That's the main thing, sir.
Actually, there is no when I was a chairman of CWSC, instead of no asking the what do you say the children to know or their caretaker or their parents to be present before us, we used to go there. So it depends. Maybe the Department of Social Defense can be contacted so that they can direct the CWC chairman to go and physically visit. They can go. There is no need that even the judges they go sometime. So they can do like that. But we need some push. Maybe social defense, being a supervisory authority, they can be contacted.
So yesterday I asked her to call her child, and she told that I have full faith in my brother. But even I told her that he's taking morphine and all type of injections and all. How can you have a faith on him? And how can you trust that your child is safe with him? She's just blind, you can say, but she has full faith that her brother is very faithful to him. I don't know how it is possible that she's thinking, but what can I say? I am very much means in chains right now.
Yes. Okay.
This the substance dependence problem that the brother has is who has told you about it? Have you met the brother?
Ma'am, I have done a few inquiry. One Seva Mission, one trust is over there, who told me about that you wanted a case with the palliative care. You want to see the patient in the last stages and all, and can you care for him? He told me about that. I have inquired each and every detail about their family, and their family is like this and that. What all I told to you that person has told. That is Seva Mission Trust. Very trustable persons are there in that trust, ma'am.
In all of okay, so what we'll do, Avatar, is if at some point we'll take this particular conversation offline, because we will try and come up with some sort of I wouldn't say solutions, but we let's think about this some more. Let's get some more details. We do have people that we can possibly reach out to, but and we'll just move on with today's session. But
Yes,
one thing I
yes,
want to
ma'am.
just mention, I just want to mention one more thing here is I'm sure the situation, I mean, it's obviously a very grim situation, and in the center of it all is a little girl who really there's no guaranteed safety on either side. There's that. There is also the side of the mother who is probably imminently dying and doesn't have much time left, and would obviously it'll be good for the child to see her. But I would be a little bit cautious treading on the addiction side of the issues, because sometimes our vision is also, I mean, people with addictions are people that we don't look kindly upon. It's a knee-jerk reaction. Oftentimes they have their own needs. They also have their own traumas. They also need help in some way. But it's very, I mean, I'm not saying that you're doing this, Avatar, but I'm just saying that it's very easy as society for us to say, you know,
Yes, ma'am.
he's got an addiction, therefore he is a terrible person, and we must rescue the child. We must, of course, get the child into safety. But there might be some things there that we need to also look into. I know that in Punjab, and because we've tried to work with opioid availability issues everywhere, and because of the massive addiction issues in those states, pain management becomes a very tricky situation there. So having said that, we do have people in our network who are scattered in different parts of North India as well. So I will be glad to take this up with you offline.
Yes, ma'am. Yes, ma'am.
And
Yes.
yeah.
Yes. Okay.
So we
Okay.
have about half an hour, Githanjali. I just want to circle back to some of the points that were raised by people right in the beginning about the change that they want to see, and we've had a variety of responses, right? And I know that everyone who's come in here to Aarohan has a vision for what this program will equip them to do. Now, someone brought up, I think Esther brought up the beautiful idea of volunteering, and volunteerism is really the heart and soul of community-based palliative care. And what struck me about what you said, Esther, is the persistence with which you've gone back and said, you'd like to be part of a system. What I hope that this program will do is help you, for lack of another word, package your message and your offer a little bit better. We have a lot of people who want to come and volunteer with us. And then the responsibility becomes the organizations to create a role where the volunteer can fit. But if a volunteer comes and says, I have these skills, and I see that in your organization, you have a need for these skills, and this is what I have to offer you, you take away one barrier.
Yes.
Because an organization that is already doing a lot does not want to stop and think about, I mean, they do work on volunteers, but you're giving them a task. As opposed to you do your research of the organization, you see how many patients they've seen, what are the kind of patients they see. And through this program, hopefully by the end of these few weeks, you will also have a more honed skill set. I mean, you already have this vast amount of, good, I mean, you're amazing. I loved hearing you. But maybe you can streamline that into specific ways in which you can plug into their program. And then that makes it a little bit easier for them to say, yes, I didn't think that you could come and do this for us, and you can. So I even with volunteerism, I think it's just good intent sometimes gets diffused. So how do we take all that good intention, put it in a way that is a little bit more in line with what the organization needs, and present it and offer it to them, and then they're able to say, hey, yeah, this is where you would fit in perfectly. Because I find it personally very difficult when someone comes and says to me, fit me in wherever you want me to be. Then I have to think, okay, I don't know. And I don't want to disrespect them by putting them in a place that they could be doing so much more, but I haven't had the time to really get to know them. Right? So does that make sense in some way?
Yes, it does. And Smriti, can I just add something? Can I just say something? To quite an extent, I have a little, I would say, a little knowledge about palliative care besides the scientific, the medicine, the medical part of it, because I'm in my PhD thesis, my dissertation is on palliative being a bridge between two euthanasia. When a person asks for euthanasia, if the fact that they ask for euthanasia means we are a failed society, that is my question. So I've gone ahead and studied all about palliative care. So when I tell someone, I am aware of it, even the little nuances between palliative care and hospice. So I explained myself about both those things. So I'm happy if, I can do something somewhere, because so there is a little awareness that I have. So I just hope that.
So a brilliant thing there is, there's a lot of people there are a lot of organizations also who would who would really appreciate having someone with your experience actually write up some of their, some of their vision, points of their vision, or clarify their messaging. I know we've had a lot of help. We've had a lot of help. We've been around since 2003, but it's only in the last year we had incredible help from another firm, and they helped us get our messaging right. Because I'll tell you what, people like us, we're so in deep that sometimes I don't know how. I mean, it takes somebody from outside to tell me, hey, your message is getting lost here.
Okay.
Yeah. So so I can tell you for a fact we've been beneficiaries of that. And to offer that kind of a skill to an organization would really take them to the next level. So
I hope it does.
Maybe that's something that can be considered.
Yeah.
We will be doing a session on media advocacy and how to engage the media, how to message and stuff like that. So maybe things will get a little bit clearer when we do that.
Okay. And there was another point. There was another point where someone picked up, about palliative care. How do you approach the patients in the hospital? So when I was meeting about over 200 families, so I think that was my one of my criteria was to see how many hospitals in Pune had palliative care available, and I was shocked that the oldest government hospital in my city did not have palliative care. So I asked them, you have an oncology department and you have cancer patients right at the end, and you have other serious patients who are reaching there. So what do you do? They said, if you come on Wednesday, we have palliative care persons coming from Sipla who visit us on Wednesday. So I went on Wednesday to the hospital and I met the palliative care, health who came from there, the nurses, the doctors. And it was a Wednesday. They said, we will give them morphine, we will give them the analgesics and everything what is there for today. I said, what about the pain from today till the next Wednesday? Are you going to give it to them? They said, we can't leave it in their hands. So I said, then are you going to give the medicine to the doctors so they can give it to the patients? They said, no, we cannot even give it to the doctors. We have to come. So I said, I was like, forget about the doctors and the people or the family members coming to give food. But I said, the patients might be waiting for Wednesday just to know that a Wednesday brings them relief from their pain. So I was very surprised about that. That was something that I realized some hospitals don't have, and they have palliation workers coming from out. So that was that answer to that. That's what I experienced as a layperson.
So one of the things we'll try and do for all of you is through our we'll be doing a session on the law, the NDPS, and also access to opioids, and what it means for an organization to be able to stock and dispense, who are the people involved, right from the state level, machinery level, down to the organization. And it is a little bit of an unwieldy issue, Esther, because even though the law was amended in 2014 and the rules came out in 2015, majority of the states in India have not implemented it. Majority of the drug controllers in India are not aware that the law has been changed. And that's what we go and educate people. Now, in such a scenario, because the punitive action, right? So if I stock and dispense morphine and I happen, because we advocated for this law, even though we advocated for morphine to be more accessible, we did say that no, it still has to be safeguarded, because we cannot, what we're advocating for is balanced access, not from no access to, the opioid crisis that America has. So there are very strict punitive conditions in place. And when it's so confusing, I don't blame the healthcare system or the medical system for being cautious, because it means that the person who, if they're caught on the wrong side of the law, the margin for error is very little, and it's like 10 years in jail.
True.
So it's so people, that's one of the problems we're facing in our country. It's the principle of balance, to prevent the misuse and diversion of narcotic drugs, but to also ensure that it is available for scientific and medical use. It's a very tricky balance, and it's very, very difficult to, it's to us, probably you can wake me up at 3 o'clock in the morning and I'll tell you about it. That's because I've spent 10 years breaking my head trying to understand it. Right? But most people would not. So I would say that once we understand the law a little bit better, then that also puts us as advocates in a better position to understand where we stand. And when criticism is warranted and when perhaps facilitation is required. So if you come across a hospital or an organization that is not aware of the RMI, the recognized medical institution and all of that, then hopefully this series will enable you to have that conversation and say, have you guys actually thought about getting a license? And it's not as difficult as you thought it was. So yeah.
Smriti, are these kind of medicines that are available are they in different cost? Are they cost effective for everybody? Because like my father had been prescribed these fentanyl pain patches, by a doctor in Batra Hospital in Delhi. He used to call me to get the prescription. He used to make me wait from 9 in the morning to 6 in the evening to sign that, and he would give me 3 patches. And one patch would last 3 days. So by the 7th day, I was again standing there, and it cost us some money, which I don't say that we couldn't afford it, but I don't think poor people could be getting that kind of facility.
Fentanyl costs 160 times more than oral morphine. Yeah.
So oral morphine is available to the poor and needy as in when they are in excruciating pain, or do they also have to go through this kind of process to get it?
So we'll make a note of this, Shreya and Githanjali. Barriers to access is something that we will talk about. Again, this is a very, very complex and convoluted subject. It can be a slightly controversial subject also. But I see that this whole group is extremely, you're all coming at it from a perspective that is quite, it's quite out there and evolved. A lot of it has to do with the industry, and you know what I'm referring to. Oral morphine is cheap, it's effective, it can be easily administered. Injective, it has far less. The chances of addiction to oral morphine are almost negligible. Chances of addiction to IV morphine is a little bit more because of the rush, the immediate uptake by the bloodstream. And then there's fentanyl and all of those things which are synthesized. There is a vast difference in the cost. But medical representatives will, and although they're all under the same regulation, the high cost medicines are the ones that become more available for prescription. It is a very sad state of affairs. It's not India alone that we see this at. But yes, what you have raised is a very valid point. Now, is oral morphine available to everybody? No, it isn't. And one of the reasons for that is it's not just about availability and access. It's about the fact that doctors have not been trained on how to administer it. There is something called opiophobia, which is now being even big. It's a huge beast also because we hear so much of it from the US, right? It dominates the news. And like I said, that's a whole other problem. It's actually not what we're facing in India. We're facing the downstream impact on the flip side. But the other thing is opio ignorance. Doctors have not been taught how to administer or titrate opioids. There is a fear of doing it. I don't want to be the guy who writes a prescription that gets someone addicted. Why do I think that? Is because I've not been educated on the fact that this is how opioids can be used. So which is why when we do our foundation course for doctors, we talk about the WHO access, the analgesic ladder. How do you actually use opioids, mild to moderate to severe pain, as adjuvants, as the mainstay. So it is a very systemic problem, which is one of the reasons why a major part of our advocacy is to get undergraduate and postgraduate medical programs to teach palliative care. Now, unless the hand that prescribes knows, how it works, I don't think the rest of the system will really fall in line. And like I said, there are people who get prescribed 10 mg of morphine for a day, when actually that does nothing for them. So it's a very systemic problem, unfortunately, Zaved. To answer your question, low-cost pain treatment is available. That's one of the tragedies of this country, that so many people are pushed into poverty because they're being prescribed high-cost medication when an alternative is available. But you can see why we're an unpopular voice when we say that.
Can I, so I'll be sharing the directory of palliative care clinics that we've been collecting over the years. It's available on the Pallium India website. As a small task, all of you all can go through the palliative care centers that are available in your town or city as a first step. And Githanjali, can we continue with the presentation, please?
Yes, I will just share my screen. I know we have 15 minutes left. And This is a very important discussion that we've been having. So, it's just very obvious just how much there is a thirst to know, and there's how much there is a lack of information and availability of information. So this is a great forum, and I didn't want to come in and cut the conversation, because it's a very important conversation to have. But I do want to touch on one or two things when it comes to the concept of goal setting itself, because as you go through this journey, you're going to go out there and do what you believe is your mission or your project that you're going to take out and make a difference, because each of us going out there and doing something is what's going to make the difference. So I'm going to just share my screen for. Please let me know as soon as you see it. Okay, so we've spoken about the one change that we want to see, and that led to this whole conversation on asking all these questions that we have, because as we think about the change we want to see, there are more questions that come up. There are more worries and concerns and fears, because the space or the landscape in which we are trying to operate and the things that we want to change are really deep and really complicated. So this is a fair area to have the discussion, and and maybe we need to schedule a session where it's just Q&A, just pure Q&A, because there is so much to talk about. But bringing us back to the project that we're working on and the focus that we want, broadly, there are three different ways that you could focus yourselves, right? You could focus yourselves on building awareness, and that could be the primary agenda for what you do. Or you could focus yourselves on influencing policy. Our projects could focus on influencing policy, or they could be on service delivery. Now, as I read through, the responses that we received to the question answers, what we realize is that depending on where we are feeling strongest, depending on where we have experienced where we've maybe experienced pain, maybe experienced some support and comfort, we have chosen projects that we think will make the biggest difference. And while we look at our projects might focus on one of these three, there will be some level of overlapping. So let me just take an example of one of our participants has said that she would like to provide yoga, right, into the cancer care recovery system and support caregivers with that. Now, that is a service that it's a great idea. It's a great service that she could provide, because that's an area of skill that she has. Others have come up to say, and as we saw in the discussion, I mean, what's the one big change you want to do? A lot about building awareness, getting people to speak about this, to understand this. So it could be about building awareness. We also saw, if there is somebody who has experience with law or has access to law and government, maybe their project is about influencing policy. And the reason I put this here is because when you look at this landscape, there are just so many things that come together. And projects that will focus on will try to focus on many different things will really be confused, right? So we need to, as you think about your project, think about what is your agenda? What is it that you are trying to do? If you're trying to build awareness, that is where a disproportionate proportion of your effort, of your time, of your focus will go. The channels you will use will be different. If you're looking to influence policy, then that's where your effort and energies will go. It will determine the types of networks you try to build. It will determine the types of conferences you attend, the reading and the research that you do. So I would first of all just encourage everyone to think about where you want to focus. What is the ultimate goal of your project, right? Moving from there, if you look at how would we enable, which channels will we use to influence and to make the change that we need? There are 4 big buckets, and I'm going to just talk about this very, very briefly today, because we have sessions that are assigned to each of these separately, individually. And so you will get really deep understanding of how they influence and how you could leverage them to support your project. So let's start very briefly on this page about, there are 4 different channels that we're talking about. We have the government. It could be, we could we could use the government, we could influence change through the government, using the government to bring about the change. And that is done when you change policy, when you get laws changed or regulations mandated, then through government, we can influence the change in the society. We can influence change through civil society, and civil society is basically society at large. Members of the society may have direct implications because of the efforts that you're taking, or they may not, right? This is just society at large, and you could use society as large to, let's say, influence the government, influence lawmaking, that type of stuff. You have media, and we know about media. I think that's especially in the last few months, the range and the access of media and basically the influence of media has just grown multiple times over. And so you could use media to be your source or your channel of influence, or you could engage with the community. And we've seen that, a lot of us want to engage with the community. And the difference between civil society and community is a group of people who have something in common. It could be that we all belong to a particular region of the country, and therefore we face similar challenges and issues, and therefore we engage with that community to bring about solution and to bring about the change. You could also have a community of beneficiaries of similar types of illnesses that they're going through, so you could work with that. So engaging with community is another channel of influence. So when you think about what is my focus, you would also then choose your channel accordingly. You might use more than one channel, but you would disproportionately use the channel that makes most sense for you, and you would work through that. So this is a very high level. Like I mentioned, we will have specific sessions on how to work with the government. We'll have special sessions on how to engage with community, how to work with civil society, and how to work with media. We'll have individual sessions on that, so you'll get much more detail there. But this is just food for thought for you too, as you continue to refine what you're going to work on and the project that you've taken on. Now, moving forward, I want to take a few minutes and just share with you the profile and the richness of the group that is on the call today, this team that we have here, and where you can find support within the team itself. And you would have seen some of that in the conversation that we just had. So we have about 44 of us here. And as you can see, variety of a good distribution of age groups, I would say, from 23 to 84 all the way, and people with different work experience. We have not only professors or academicians, but we have people working with others who are in, either they're as caregivers or in life-limiting disease, working with people with those illnesses or working with elderly. So you have a good range of experiences in this group. The next thing I want to share with you is the profile of our participants. They come from across the country. So when you look at the project that you're working on and where you want to focus yourselves and which areas, there is information and knowledge from across the country in this room here. So as you look at building your network, here is one place that you can look at as well. If you look at experience that this group has had, we have at least 50% or 45% of our group with experience with advocacy. So we have people in this room who have written articles, who've done radio shows, who've had conducted webinars and awareness campaigns. So there's a lot of support that you can find within this group itself. For those who don't have, we have another 55% who have not done this before, but there is that support for you in this group as well. And I share this because all this, when you look at the resources you need to build your project and the resources and the support you need to build your project, here are some of the resources that you can find. Moving on, as we looked at the projects that people had written about in the questionnaire, we found that across the board, you can look at this list, we have intentions to work with a variety of beneficiaries, right? All the way from caregivers to people with to cancer survivors, with people with dementia and Alzheimer's. So this is again just a wide range of topics that people have been talking about. So what we're going to do is definitely share with you all a collated list of I think I just received a message saying they can't see my screen. Are you able to see your screen? See my screen?
We are able to see it.
Okay, excellent. I think we have Jean. Gina saying that she is not able to see the screen. Just check with Gina.
Hi, Githanjali. I'm seeing a PPT says, what is the one change you want to see? But I think you're sharing some other list. Is that right?
Gina, you need to log out and log in again.
Oh, is that it? Oh, sorry to interrupt. I thought there's a problem. Sorry.
No. Okay, so moving on. So we'll share. We've got a compiled list of the projects that you all responded to. So we will definitely share that, and you can see. And the reason I'm like I mentioned before, reason I'm sharing this is for us to be able to see the variety that is within this group. So together we can make a difference. Advocacy channels, we asked a question about which advocacy channel that you would like to use or engage in to build or make the change that you want to make or work on your project. And you can see that most people are focused on community engagement and social media. As you go through those sessions, you might change your mind. You might find other ways that you can expand and influence. And we will come back to this later then. Now, we asked a question on resources available. What are some of the resources available? And as you can see, people did, as respondents, we did go back and think about all the things that we have at our disposal, whether it is experiences with volunteering, whether it's a law background, whether it's a medical background. So again, a whole slew of resources that is available within this group. And the reason we're sharing all of this is, as individuals, we might not have access to all of these resources, but as a group, we do. And that's where the difference comes, and that's where the importance is. Resources needed, proposal writing, grant writing. There might be some things over here that we as Palliative India can support with and educate with. It also gives us food for thought in terms of what resources we need to bring together. Now, as we asked you about, what is the most important aspect or what you will need to commit to get this work done, most of us said that time and effort is the most important piece. Fair enough. I think that is what we would have expected. But it's equally important to keep the energy and the enthusiasm we need to get this through. The reason I say that is because getting from conceptualizing of an idea to the delivery of an idea is long, time-consuming, and a lot of hard work. And that's where this group needs to come together to support. Now, before we close, I'm just going to talk a little bit about a few things to keep in mind as we go on. So what's going to happen from this point on into the next, when you go to phase 2 of the learning, which will start in January, what's going to happen is that we're going to share details about the different aspects of influence that will help you with your projects and with your initiatives. And now is just the time to step back and think about your initiatives in a deeper way. And to do that, I'm sharing with you a few ideas to keep in mind. The first one is that impact is not determined by how big or small the initiative is. The important thing is to do something, and it can be anything, but the important thing is to do something. The second idea to keep in mind is that change will take time. Progress can seem slow at times, but every step is a step forward. Those are two things I'd like you to keep in mind. The third thing that I like you to keep in mind is that the burden of care affects everyone that we meet, that we know. And therefore, what that also means then is that you can find support, you can find help from quarters that you may not even have imagined. If you can ask the question properly, if you can articulate yourself, if you can get to what you need, you can find the support that you need. And finally, I think this is one of the most important pieces to keep in mind. It is that people are hesitant to talk, to ask questions, to understand. Obviously, it's not a problem in this particular group, but it is a reality, right? We don't want to ask questions, we don't want to understand, we don't want to engage in discussion. And a lot of the times it's because we are afraid. But that has its own negative implications. So it is equally important for us to educate ourselves, to ask questions, and seek answers as we build our projects out. So with this, I'm going to leave us, I know we're at time, so I'm going to leave us with just a little, I'm sure you know the story. This is the story of the starfish. It's about a man who was walking along the beach, and he saw a boy picking up something and throwing it into the water. And he asked the boy what he's doing, and the boy says, "I'm throwing the starfish back into the water." So the man looks up and he sees that there are miles and miles of beach where there are starfish that have been stranded, and the tide is going out. So the boy says that, if I don't throw them back now, the starfish will die. And the man is a little confused because he can see that this boy is never going to make it to save every single one of those starfish. So he says, is this really worth your time? And the boy picks up another one, throws it back into the water, and said, I made a difference to this one starfish. So remembering that, we are here for a purpose. It doesn't matter how big or small the impact is, as long as we can keep our eyes on the ball. We remember who brought us here, for whom are we doing this project, for what are we fighting for, making sure we remember that. And if we can make a difference even to one person, we've made the difference. We've made all the difference we need to make. So with that, I'm going to finish the conversation today. I know there are lots of questions and lots of things that we would like to continue the discussion on, and I'm sure there'll be an opportunity in the next call to continue that discussion, but otherwise the WhatsApp group is always there and we can continue talking. So with that, let me just turn it over to Freya.
Thank you, Githanjali. Thank you, Smriti. Githanjali, can you stop sharing?
Yes.
Usually we are going overboard with the time, but Smriti has a webinar to attend. So please do attend the webinar if you have the time and energy. It's at 5:30 to 7. Ashla is also going to be there. So please attend it. And if any questions, because it's already time up, write it on the WhatsApp group or for any questions that you have. Next week, we have a session on humanitarian crisis. It's the last session for this year. So you all can enjoy your Christmas and New Year holidays. So please attend the next session. It's a lovely human being you're going to be meeting, Joan Marston. It's a session you can't miss. So thank you all so much for being there today. It was, some questions are unanswered. We'll get back to everyone. But please do use the WhatsApp chat as well, because all of us are there. So thank you. And have a good weekend. And please do join the webinar. The details are sent on the WhatsApp group. Thank you so much, everyone. Thank you.
Thank you.
Thank you so much.
26th, we don't meet, right? 26th?
16th.
Sorry, Modi. 19 December is the last session of the year.
Thank you.
Okay. Thank you.
Thank you so much.
Very much.